Welcome to Health Code Blueprint. Today, we're focusing on ICD-10-CM. Chapter 10, Diseases of the Respiratory System, covering codes J00 through J99, along with U07.0 for vaping-related disorders. In this session, we'll break down key definitions, clarify sequencing rules, and highlight the documentation details that influence accurate code assignment. Disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. So before we jump into the specifics, let's ground ourselves in the four big decision-making pillars for Chapter 10. First, we define what we're looking at. Is this uncomplicated, or is there an acute exacerbation? Then we sequence. What's principal, what's secondary? Next, we confirm, especially important for influenza. And finally, we attribute, meaning we establish cause and effect, like VAP or vaping injuries. These four steps guide every respiratory coding decision. When we talk about COPD or asthma, the key question is the patient decompensating? Clinically, an acute exacerbation means the chronic condition has worsened beyond the patient's baseline. And here's the nuance. An infection doesn't automatically equal an exacerbation, but it can definitely trigger one. So as coders, we're looking for documentation of worsening, flare, or decompensation before assigning those J44 or J45 exacerbation codes. Now let's talk respiratory failure, one of the most debated sequencing topics. The general rule is straightforward. If acute respiratory failure is the condition chiefly responsible for the admission, it can be sequenced as the principal diagnosis. But remember, some chapters override this rule. Obstetrics, poisoning, HIV, and newborn guidelines always take precedence. If respiratory failure develops after admission or doesn't meet principal criteria, it stays secondary. Here's where things get interesting. What if the patient has respiratory failure and another acute condition, like an MI, stroke, or aspiration pneumonia? Your job is to determine whether both conditions equally drove the admission. If yes, Section 2. C applies. Either one can be principal unless a chapter-specific rule says otherwise. If not, sequence the condition clearly responsible for the admission. And if the documentation isn't clear, that's your cue to query. Influenza is one of the few places where ICD-10-CM breaks its own rule. Normally, we need diagnostic certainty, but for influenza, confirmation is based entirely on the provider's statement. So if the provider documents H1N1 influenza, you code it as confirmed even without a positive lab test. But if they say suspected, probable, or just influenza without specifying a strain, you default to J11. Let's break down influenza coding in a way that actually sticks. Think of it like picking the right lane on a highway. Each lane has a purpose. J09 is your special circumstances lane. This is where novel or avian influenza goes, the high severity, unusual strains. J10 is your identified strain lane. If the provider names a specific, non-novel strain like H1N1 or H3N2, this is where you land. J11 is the we're not sure yet lane. This covers cases where the strain isn't identified or the provider documents terms like suspected, probable, or possible influenza. And the key rule to remember, if the case is suspected, you cannot use J09 or J10. Suspected influenza always defaults to J11. Ventilator-associated pneumonia is one of the most documentation-sensitive diagnoses in ICD-10-CM. Just because a patient is on a ventilator and has pneumonia does not mean you can code VAP. Timing alone isn't enough, you need explicit documentation of ventilator-associated pneumonia. If the relationship isn't clear, you query. No assumptions allowed. When VAP is documented, here's the coding workflow. You assign J95.851 for VAP. You add an organism code if one is documented, like B96.5 for Pseudomonas. And you do not assign additional pneumonia codes from J12 through J18. If the patient was admitted with pneumonia and later develops VAP, the original pneumonia stays principal, and VAP becomes secondary. When the provider documents lung injury due to vaping, U07.0 becomes your principal diagnosis. Then you add codes for the manifestations, like acute respiratory failure or pneumonitis. Respiratory symptoms such as cough or shortness of breath are bundled into the diagnosis and not coded separately. But GI symptoms, like nausea, vomiting, or abdominal pain, can be coded separately. Alright, Let's bring everything together. When you're coding COPD or asthma, the big thing you're looking for is whether the patient is actually decompensating. That's what drives the exacerbation codes. For respiratory failure, always go back to the hierarchy and sequencing rules to figure out what truly belongs in the principal position. With influenza, remember that the provider's statement is what counts, not the lab results. For VAP, the documentation has to be crystal clear. No assumptions, no shortcuts. And when it comes to vaping-related injuries, U07.0 is your starting point, and then you layer in the manifestations. Accurate respiratory coding really comes down to understanding the provider's intent and applying the right logic at the right time. Thanks for watching Health Code Blueprint. See you in the next video.